better sleep, sharper focus, a healthier life? It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Meggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hey, everybody. Welcome back to our podcast, No One Told Me. We are super excited about our very, very special dear friend and guest, Jeff Rouse, our mentor and intro to airway dentistry. Thank you for joining us. I'm like all nervous. I feel like you're a celebrity and I'm still nervous around you. Still scared of you.
You know better than that. It's great to be here. Thank y'all for inviting me. I'm surprised I wasn't the first guest and disappointed, I guess, but it's making
You're hard to get.
You're hard to get. You're busy. You're busy.
And we had to practice, right? We had to start to learn how to speak.
Yeah.
So, yeah, well, thank y'all. Thank you. I really appreciate it. I'm really proud of y'all.
Thank you. I recently texted you. I just said, do you have any idea the ripple effect that you've caused that continues? Because, so for those of you that are just new to Jeff, he is a phenomenal prosthodontist and an educator, and he is a pioneer in adding the word airway to dentistry, and he is absolutely responsible for my aha moment to connect a lot of dots. And the other day, I had a parent of a patient reach out to me and thank me for profoundly changing their kid's life. And of course it feels good, right? Like how powerful and significant does that make you feel? But my first thought was, I wonder if Jeff recognizes the amount of impact he has created by teaching all of us, because we're all going out and doing your work to spread this message. And it's just so cool. Do you ever think about that?
Yeah, actually it kind of sounds egotistical, but the answer is yes. I think about it a lot. And it was actually planned, and it was planned as penance for me missing my own son. So y'all know the history, but I'll just tell people a Cliff's Notes version is that I came to learn about airway by actually looking at bruxism. And I couldn't figure out why people brux their teeth, and I got involved in it. By about 2010, I had a decent idea as why people would brux. And we can talk about that if you want, but and it was airway. At its core, it was airway. And then the more I started looking at airway, the more I went into, okay, let's go historically back and look at the young kids because they tend to brux more. Why would they do it? And I went, oh crap, they got an airway problem and it triggers this and this and this and this. And I went, that's Jake, that's my son. But by that point in time, he was 6 and he had gone through 3 surgeries and we're going to end up getting him into ortho right after that. But I had missed it completely, even though I was kind of I actually came to it in 2008. He was born in 2004. So I missed the first 4 years for sure because I didn't know anything about it. And then I missed the next 3 years because I didn't pay attention. So he's coming up on 7 and I'm like, he has all this. And now he has attention deficit, dyslexia, dyscalculia, dysgraphia, anxiety disorders. And so at that point, when I started lecturing about children and the fact that we need to be involved earlier than what we really are, even though as a prosthodontist, I didn't see them, children in my practice, I started getting them for examinations because I wanted to find them. And it was once again my way of saying, I'm sorry I missed you. I'm going to try to make these kids better. But with a very purposeful thought, I began lecturing, and the lecture would be titled, Who's Your Jake? And so it was always about, you've got to find them. You got to find them early. And Liz was helping me out this weekend with our course out in Scottsdale. And every time I do one of the bigger courses, I always make people make a box on a piece of paper. And by the last day I'm lecturing, that box is labeled Jake, and within that box has to be a name. And the name is someone you're going to go home and guarantee me that you're going to try to figure out if they have an airway problem. And so, yeah, it's penance for missing Jake and sort of my way of trying to find other people's Jake. So maybe they have a bigger impact on their child than I was able to have on Jake. So I
I
do.
think that's one of the most impactful parts of your course is really humanizing and looking deeper into each individual story and then having everyone else have that ripple effect when they go home. Because then they don't just help one person, they help more and more and more. So it really is a ripple effect. It's a good way to put it, Megs.
And so
I have a
hopefully
couple of,
stars
oh, go
up
ahead.
in heaven. So
Yeah.
so hopefully I'm building a nice ledger sheet in heaven. When I get there, I got some credit I can work off of. But the other part, as y'all know, is the people always complain about I can't find a team, I can't find this, I can't find that. And you know, because I know y'all have experienced it, that your team typically comes together because the people on the team find someone in their own world that's impacted. Like I couldn't find an ENT until the ENT looked at her son and went, "Oh crap, he's got that." And then she did surgery on him and went, "Yeah, okay, I got to do this." And now she was
The
all,
two phrases I say all the time are, once it's personal, it's impossible not to be passionate. And Liz, I hear Liz say this all the time too. Once you see it, you can't unsee it, right? And so, you don't want your ENT's child to be sick, but you also kind of hope that they can see it from through a personal lens because it is very aha.
yeah. It's
Um,
and it's interesting there. You know that if they scan their life, their immediate family, they're going to find a problem. It's
totally.
that
Mhm.
prevalent. So all you have to do is create enough of an awareness that they look around and open their eyes and get past the old dogma, which um, takes engaging with it personally, because that's the quickest way to get over it. So
I want to go back to one thing you just said
yeah,
because I think it's really important. And personally and selfishly, I'm always trying to explain it. I'm trying to take your words and then spit it back out, and I'm not very articulate at it yet. Can you explain to the people listening how you started with bruxism, and in an elevator pitch, how that relates to breathing? Like, how can you explain that to the masses that grinding your teeth is not, I'm stressed with day-to-day stresses, it is a breathing problem. Go ahead.
Can I add on to that
Yeah.
too? Can you just tell people what a prosthodontist is? Like help them understand that you're looking at the minutia that comes with dentistry and then extrapolating where all of this stuff
Yeah.
comes from. Like once you were a GP, you took it even further in your education.
yeah. All right. So I'll start with you actually do a really good job, Maggie, because I've listened to you explain it. So you
God,
don't
I
get
was always hoping you were never
all the
listening to me.
credit. Um, the prosthodontist part is general dentist obviously can do any of the specialty procedures up to probably oral surgery, take moving faces, orthodontic surgery, right? But the rest of it, you can take out wisdom teeth, you can do everything. Prosthodontics is anything prosthetic, which is any artificial thing, and it's any from the neck up. We can replace eyes, noses, ears. We can do all kinds of things, but I focus in the mouth. Um, it's not looking so much at fixing a thing, but fixing the entire unit. So what instead of why did I broke a tooth, what do I need to do to fix a tooth? We look at why did you break the tooth? And then try to attack it at the why rather than at the how are you going to fix it. So if I can fix the why, then the how lasts longer. So with that in mind, I actually was a family dentist for 14 years. And so I did everything from we started our patients at 6 months um, and introduced how to take care, what was about to happen, how to take care of their teeth. That was our first visit with kids. If I was doing it again, actually, I would probably start with pregnant moms, and explaining the pregnancy and explaining the breathing during the pregnancy and the impact of apnea during the pregnancy. So I would probably add that part to the equation, and I would see the kids sooner. I would see them soon after birth just to
Talk a little bit about that. Talk a little bit about what you would do with these pregnant moms and why it matters.
You know, the interesting thing is the deeper we start going into growth and development in utero, the impacts we see actually can be discovered in utero. First of all, there was a study on oral facial tone and tongue tone and facial growth and development where there are certain myofunctional milestones that need to be established that you can look at in utero while they're going in for their normal exam. So in theory, by doing ultrasounds, you can start seeing if there are problems that are going to come. For example, if the child will be born with a high vaulted palate, you can tell that in utero. But the bigger ones are that mom's apnea during pregnancy can have an impact on the child. And it can just be overall stress of, stress of growth and um, premature birth. It can be high blood pressure in the mother. So I'm blank on high blood pressure in the mother.
Preeclampsia?
Preeclampsia. Preeclampsia, they've actually done a few studies on where they look at women with preeclampsia and they put them on CPAP and it resolves. And then they looked at the moms that were predisposed to having it and they managed their airways through the pregnancy and they never got it. And then they've done studies on, for example, everyone's trying to find an answer to autism, which will be multifactorial, and it's eventually we're not going to find a thing like Tylenol or whatever. We're going to find multiple reasons. And one of the reasons that they found is that moms with apnea, children with apnea, and then there's a marker for autism. So if all three of those things line up, the child will have autism. So if you can resolve the mother's apnea during pregnancy, then you take one of those factors out, then the risks go down.
The tipping point. You modify the tipping point.
Yeah.
So the scale doesn't slide.
So so I think that's where I would start. If I was really, really back to the family dentistry model, I would start with going around OB-GYNs and helping them with the mom and making the airway better through that period of time, be it by delivering CPAP or oral appliance or mouth tape.
Myofunctional therapy even?
Anything, whatever it is,
Yeah.
anything you do better. Anything that's better is going to be better. Even if it doesn't fix it, it's going to be better. And then, I would start early on kids because I think what y'all are doing and talking about a lot and tethered tissues, I think are incredibly important. And
Can you touch on the bruxism and the breathing?
tethered tissues or
No, bruxism.
Oh, yeah, I'm getting there.
Okay, sorry.
So, you can't really detect necessarily bruxism until you get teeth to send you the signal. And so the numbers I know are on 5 and 6-year-olds, where about 30% of them are actually grinding their teeth. So we'll use that as a baseline of, early, and at 60 years old, it's about 3%. So it goes down throughout life. Okay, so that's the first thing. And if you look at apnea, it's really, really low as a kid and really high at a 60-year-old. So it's an inverse relationship between those two. And with that in mind, I was like, well, wait a second. If bruxism is related to apneic events, then why wouldn't kids have more apnea? And why wouldn't you grind more if you had apnea? And so that's where it really began. I wanted to figure out why people ground their teeth. And I thought at the time it was to prevent my restorations from breaking. Because that's what I was taught. I was taught if you do rehabilitation, make them a night guard. If they wear the night guard, you're never going to have any problems. You'll just have an occasional tooth that bumps into one another and it'll be okay. But what I found in practice is completely different when we started evaluating it. So we got this information about airway, we got the information about bruxism, and it kept showing that there was a relationship there. But the more apnea they had, the less they would grind. And so my mind was not being able to wrap around that whole concept because I'm thinking your airway would shut down and your body would just react by, and then you would open your airway. And it kind of worked, but it didn't exactly work. And then I met a guy named Gerald Simmons down in Houston who's a sleep physician. And Simmons and a dentist, an oral facial pain guy named Ron Preen, they were doing a bunch of studies looking at bruxers, but they were doing the sleep studies differently than most people, where they were, instead of looking at apneic events, which is a complete obstruction of the airway, they were looking at changes in pressure gradient, which would mean it's way early in the process. The airway just starts to shut down. And what they found is that it wasn't so much the airway obstructing that caused the bruxing, it was that the airway begins to shut down and the body reacts to it and goes, wait a second, we can't let that happen. And the reaction could be you roll over, you wake up, you cough, you move, you whatever. But one of the reactions can be that you move your jaw around. And when you move your jaw around, it is possible as well to put your teeth together because you'll fire your muscles more, which means it's more effective at opening the airway. And they found that over and over and over again. Well, the reason it didn't make the traditional literature is the traditional literature, especially the famous stuff coming out of Montreal, they did not measure minor airway events. They only measured major airway events. So they had this data set that had this whole section that was unexplained. Like what? Okay, we got these people, but what about all these? And they were like, well, we got to come up with another explanation for them. And in fact, they just were working with an incomplete data set. And unfortunately, they still are. The majority of people that are still working on this area of bruxing, the labs are not giving them as the details that they need. So see, I got
Thank you.
around.
So wait, because
Patient.
you published your paper, The Relationship Between Bruxism, Acid, and OSA in what, 2011? How
Yeah.
long had this been on your mind? Like, how long did you feel like you were kind of an outlier and a thought leader in something that you couldn't quite prove?
Uh, it, I had been looking at bruxism since 2004.
Mhm.
In 2008, I found the stuff on Airway. So for 2 years, I looked at it. And that, by the way, that's the other protective mechanism is if you get any reflux in your oral pharynx, you have to be able to buffer the pH, which means you have to put your teeth together to create saliva. And so bruxing is a way of creating saliva to protect the airway from acid. So those are the two protections. One protection is the closure, the other protection is the acid. And they're actually intimately linked because the closure creates the negative space that brings the acid up. So they're one
The
and the same.
vacuum.
Yeah, they're one and the same in that regard.
So
So 2 years, but that's when I wrote the article. I've been fighting this forever. In fact, I don't remember what year, but let's call it 2014 or so, 14, 15. Um, Greg Kinzer was lecturing at the Operative Academy. And so Greg and I teach together and actually we're writing a new textbook and all the airway stuff we did together. So he's very in agreement with all this. But now it's 2014, which is 6 years, let's say 6 or 7 years after I started talking about it, writing about it, because I've written multiple articles by this point. And he came off the stage at the Operative Academy, and a friend of mine went up to him and said, "Hey, that was a great lecture, but you talked a lot about tooth attrition and bruxism, but you didn't mention airway." And he said, "Yeah, you believe everything is about airway, all about airway. It doesn't have to be all about airway." And now if you ask him, he'll go, "Yeah, okay, it's all about airway."
We've started this collection of t-shirts, right? Like something is sparks a t-shirt design. And my favorite one that I've seen so far is the one of you spilling the story about you spilling the wine and everyone thinks or you say that it's airway.
Yeah, that was a next door neighbor. He's not even a dentist. I, I spilled a glass of wine and he goes, "Oh, it must be an airway issue, huh?"
probably is, probably is. It is. I mean, the trickle down effect of health and oxygenation and breathing and sleep, it's so impactful but it's so multifactorial. So I think that's the hardest thing is to try to isolate and prove something in the literature when there are other factors at play, because we can't withhold beneficial treatment from people. So I think that leads me to my next question. Where do you think we need to go to help bring this message more mainstream? Like, if we can't isolate and dial in literature, how do you feel that we can keep directing people towards asking better questions about their health?
Um, well, okay. I I guess the first part of the question is the literature today is significantly better than it was when I began. And
New stuff every day.
the neat part about it, and it's unfortunate that Christian Guilleminault passed away because he was leading, he was a sleep physician at Stanford that saw the role dentistry could have, and his literature that he was producing was driving everyone towards just get the anatomy correct. His key, though, is he said you have to do it early. If you do not get to it as a kid, you will never fix them. And it's just because they're neurologically damaged down the road. So unfortunately, some people took it as, well, I missed it, so let's not do anything. And it should be, you're never going to fix them, but you'll make them better. That should have been the end of the sentence rather than just, you're never going to fix them. Um, so the literature is better. I don't have to weave as interesting a tale as I used to have to weave whenever we were doing this. I can just tell you what the current literature is actually saying. And um, but how we continue the discussion is doing things like this. And and um, the other part, I guess, would be a change that I made 3 or 4 years ago, um, which was stop trying to fix them.
Yeah.
Like, try to do the best you can, but don't assume you failed if everything isn't great. Because the smartest guy in all of sleep medicine said, you're not going to do it. It's impossible. And yet we still not kick ourselves if you do all this stuff and they still, oh, I still snore. Like, okay, well, but you're going to live a lot longer,
Well,
guaranteed.
I think that that point specifically is also a barrier to dentists in particular wanting to jump in and start to evaluate and be aware of it, because that's daunting and like, oh my gosh, that's a lot of pressure and a lot of responsibility. I think that leads really nicely into my favorite thing that you say is, well, second favorite thing. My favorite thing you say is you got to let some of them die. My second favorite thing you say is just do dentistry. And I think that by knowing that we can tip the needle and make people healthier and decrease their dental risk and hopefully help them breathe better is enough for us to do. It doesn't have to land on our shoulders, even if we are in a perfect position to be the quarterbacks and the identifiers. We don't have to be the individual solver either.
Yeah. So you got to you got to let them die. Um, that 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 was basically that was people that were fighting to not do what needed to be done.
When
Like,
you cared more than they cared about their airway.
exactly. It's like, this is what you should do. Well, I don't want to do that. Yeah, but I'm telling you, this is what should be done. Like, you need to listen to me on this one. And at some point, you have to just let people do what they want to do. I mean, we were having this conversation earlier on the WhatsApp chat, which was just
Yeah. We're perfectionists, right? Like
sometimes
we're
you have to let them suffer, right?
it's hard. It's like we're looking at the big picture instead of this tiny little cusp of a tooth. Like, we want everything perfect. But how do you find perfection? You can't, because there's no such thing as perfect when the skeleton no longer is. And when you mentioned Gimeno, one of my favorite things that he's ever written talks about the first latch at birth at the breast and how it creates airflow because it creates a distraction in the brain that eventually shrinks the turbinates. And if that's compromised, which it is in so many cases because we have such an ability to keep people alive earlier and have them be born so much earlier, like our ability as humans in medicine to survive is so much higher than it's ever been. But thriving is kind of the question. So you're right. We need to like tone down our perfectionism for a minute and be okay with we made you better. So thank you for reminding me of that earlier today. I
Well,
needed
I
it.
think when you turn down your perfectionism, you get the opportunity to help more, because if you're not going to hit perfection, sometimes we don't even go for it, and then we're not making any difference. We're not making any improvement. So yeah, I think that's a really powerful message.
And a lot of people, where the just do dentistry message came from is out of that, which is I would hear from people that took the course and came back a few years later and we're, hey, how are you doing with it? And they go, well, I couldn't find an ENT. I'm like, okay, can you do anything else? Well, I couldn't find an ENT to take out tonsils and adenoids. I'm like, yeah, that do something. Don't, do, and then the evolution was, how about we just do dentistry? Because we have much better control over the interdisciplinary team in dentistry, because that's the same interdisciplinary team we're going to be using when we do any of our dentistry. I mean, if we're going to intrude teeth and, do a MARPE or whatever, and do some SFOT periodontal surgery and orthodontic, all those team members are already established for cases that we've been doing for years. Everything that we've been wanting to do and proposing as far as making a beautiful smile with a great bite is exactly what you would do to make them healthy. They are the same treatment plan. And then if they say, I don't want to do that, then you know what the compromise is. You go, okay, this would get you the best smile, bite, and airway, and therefore the best possibility at health. I don't know how it's going to be. It's going to be better because it's pretty dang rare that you would go through that and make someone worse. But so it's going to be better. I just don't know how much better because I don't know how damaged your system is. So in the end, you'll have a great smile, you'll have a great bite, you're going to be somewhat healthier. I hope it's great. And then if you say, well, I won't do that, then we know, okay, now we're to here. And in fact, if you say, well, I don't want to do that, but I will do this, you can sometimes go, well, that's going to make it worse. So I can give you a smile that's okay. I can give you a bite that's fine, but it actually is going to probably compromise your airway, which means if we do that plan and you start seeing these things happen in your life, then you and I need to visit again and we need to probably create, an appliance to manage it. So it's comfortable to know, to be able to preview things like that. And then when you finish, if there's still compromise, that's when you use your other tools. But I used to spend so much time fretting over the fact that I didn't fix them. And then I go, okay, well, who do we send you to now? And like, I got to get you to an ENT, and then you have to fight the ENTs, and you'd have to fight medical insurance, and then, well, but what about this person, and what about that person? Now it's like, okay, you probably ought to go to see the myofunctional therapist. You probably ought to go see an ENT, but I'm not seeing it as a failure. I'm just seeing it as the next step that they have
Well,
to
and
take.
you're doing the patients a favor because you're creating awareness, right? And so if you say this is the best ultimate thing that you can do to fix your structure, your function, your bite, and your airway, and they decline, well, now they know that there's residual risk,
Yeah.
or there's not an ENT around, or they're not doing myofunctional therapy. There is residual risk that's not being addressed. Now, if the dentistry fails, it's not landing on you. And if you get the opportunity to work with an interdisciplinary team and you get to make things more optimal, how much more predictable and fun is that dentistry? So I do think it's,
That's what I love.
yeah.
We're just wearing dentistry. I just want to do that kind of dentistry. That's the fun stuff. But because you get this extra bonus of making people healthy, that's the coolest part.
The cherry on top.
Mhm.
I mean, you've been endlessly influential in my life, and I know that I've said that to you many times, and I hope you know that. But so many phrases that you say just are really sticky. And the other one you kind of alluded to just now is the airway positive, airway neutral, and airway negative. And just having that awareness as a dentist, whether or not you acknowledge that we have influence over the airway and the airway has an influence over our part of the body, we are going to be negative, neutral, or positive. And everything we do has that kind of um, possibility.
Yeah. It also, the other part of it, we'll just talk about because we're focused on the actual treatment. What I have found really maybe equally as important to the awareness perspective or the discussion of airway is being able to do more cases. Because when you walk in a room and you look at someone's smile and you go, oof, man, that could be improved, right? That they really ought to, right? That's a difficult conversation to go, wow, unless they came to you for that. If they just walk in and they moved in down the road and you walk into a hygiene visit and you go, wow, that's, right? That's hard. And then if you look at their function and their teeth are all jumbled and malocclusion and wear and all, like that's even a harder discussion to just like bring up. And the way all of us, I think, react is we tend to push it down the road. Like maybe if they come a few times to hygiene, they'll trust me more. And when they trust me more, then I'll be able to tell them, ooh, you're ugly, right? Ain't gonna get any better. It just isn't. If you walk in the room and see all those things that we used to actually call aesthetic and functional, and instead see it within the envelope or within the framework of airway, now the conversation's easy, and you just say, I say the same things every time. It's interesting. I was looking at your smile and what the current scientific literature says. That's the first thing out of my mouth every time. The current scientific literature, which now I'm speaking from a position of authority, and I say the current scientific literature is telling us that people with narrower smiles or crowded teeth or bites like yours or wear like yours typically have more difficulty breathing at night and during the day. Tell me, how long's your wife complained about your snoring? Or do you wake up at 3:10 or 2:47 every morning and find it difficult to return to sleep? Those are two key questions that will elicit a response. And if I get a response or see them respond to it, then I offer them an opportunity for a more comprehensive exam. That's where you can go through the whole workup and the presentation and all the rest. But walking in, seeing ugly, walking in, seeing bad function, those are really hard conversations to get people to come back for more information. Health is easy because everyone wants to be healthy today.
Do you see and feel that there will be a shift in the institutions that are teaching dentists and hygienists in the next 5 years?
No.
No. You think we're still stuck in our ways and this is all
Problem,
something that people have to seek?
yeah. The
It's
problem you have is there are a handful of problems. One problem is that dental schools have to reach CODA standards, which means that there's a set thing that they have to teach, and anything outside of that is sucking up time, and they have very little time to meet those standards, which is stupid because while I needed to kind of know embryology and, some of the ologies, I didn't need to know them at the level that I spent time. I needed to know more about well, back in the day when I was doing it, we had a lot of time in clinic and we had a lot of patients, which is different now, right? But I didn't need to know man, if I could have done without biochemistry, that would have been really good too. So
you can just Google that now.
I, you know, I, I'm impressed when people can pull that up at a dinner party and say something, but the next time I draw a benzene ring will be the last. So I just croak.
I'm
I'm
So
bummed
over
to
at
hear
that
you.
point.
I'm bummed to
the
hear you say that. What do you think will shift towards airway dentistry becoming the standard and becoming normal? Is it just going to be seekers? You don't think it's ever going to be there?
in dental schools? No.
No, just in dentistry,
Oh, in dentistry. Well, okay. Let me get back to dental school first, and then I'll get to dentistry. So dental school has CODA standards they have to meet. They've got all these hours that they have to do. But one of the biggest problems with improvements in dental school is the lack of support of faculty for continuing education. So their faculty do not get really good continuing education. They get what comes to the school, and it's usually the speakers that would go to a school to lecture for them are not cutting edge speakers for the most part. They tend to be product driven, or so you've got educators that typically are cloistered in the dental school that don't get great education, continuing education, and are typically not growing, you know, to where they see a different vision. And even if they see a different vision, because I had a friend in Maryland that was trying to institute it, it was slammed because it it now you have to, he's going, and it's this problem, and it's this problem, it's this problem. And the rest of the faculty were like, well, but no, stop teaching that because we don't know anything about it and it doesn't tie in and all the rest. Um, so I don't think dental schools will ever do it. And the other part is then you also have to think through who the most important specialist is in your group, which is an orthodontist. An orthodontic faculty, they're still teaching from, the old school, the old world. And so they're not evolving at all. And so your main players are not evolving. How does it become more regular in dentistry? It's gonna take your generation and probably the next. And the key right now is y'all mentioned in the introduction that one of the things I've focused on is the word airway as opposed to sleep, and differentiating those two, and people conflate them all the time. So they'll say, my patient has an airway problem, their apnea level is 23. Well, those are not. That's an airway problem in a moment in time. It's not an airway problem. Airway is structural. So the next step for your group of people in educating is because I got people to say the word airway. I just didn't get to say it right. Now y'all have to get people to say it correctly and really focus on it correctly. And so when you stand up at a meeting and ask, have you evaluated your patient for airway problems? And they say the apnea level is 23, or they refuse to take a sleep test, that's not the answer. You have to call them on it and go, no, what I meant is airway, not sleep. What? And the answer is yes, you evaluated because you did an exam. You just didn't see structural issues as airway problems. You saw them as dental problems that you're going to have to address from a tooth to tooth positioning type of issue. So the next step is getting y'all to focus in on getting people to use the term correctly.
Well,
And
yeah, I recently said this with Liz. We're on GDE, and kind of the way I look at it is your version or the interpretation of what you were trying to say for airway dentistry is sleep dentistry, right? And the biggest miss for that is that it's adults and it's sleep. Whereas I look at airway as it includes children, and it's the people that can't breathe at night also can't breathe all during the day. You can't just do one or the other. I mean, you can't
oh,
just do sleep and impact their daytime
it is
breathing as
very
well.
rare that a person um, that has a problem at night when they're asleep doesn't have a problem while they're awake. The structural issues are there during the day, and they're exerting more effort to breathe during the day, and they're using more energy during the day than they should. So their heart rate variability is going to be off, their inflammatory markers will be off, everything's going to be off. And so you can resolve the daytime probably, and we don't study daytime very much or very well, but I would assume that by making corrections in anatomy, the daytime happens pretty readily. And then the nighttime happens to the degree that the body can heal itself. So,
Well, it's
I
so
don't know.
fun to have you on. I, again, like Meggie said, you've been so influential to all of us, and seeing the battles that you've fought to bring this awareness to people and bring it to an educational platform has only inspired us to do the same thing. So I really hope that we can all kind of keep doing this together and bringing some more information to people, because like Maggie said, it's disheartening to hear that we don't think it'll be in the dental schools. But as you were saying that, it's also not in the speech path school. It's not in the lactation schools. It's not in the pediatrician schools. Like, we're not looking as comprehensively at these issues as we should. And I was thinking a bit about how we don't have room for our wisdom teeth, and we've normalized that. And then we have this whole generation of patients who have 4-buy extractions. We've also normalized that, and oftentimes those people are sick, but we're just saying, oh, this is new. It's really that we're treating things differently with expansion versus retraction protocols. And so it's brought this whole new level of conversation to, like, it's not new, it's been there all along. We just missed it. Kind of like you said, you missed it for Jake. Like, we all have those stories, and
You know,
they're sadly going to keep driving the bus forward.
if you actually go back in time, so to the early 1900s, Edward Angle actually expanded everyone. So it actually, we're getting back to where we originated, not the retraction component of it came in the middle. So if all we did was go back to our roots, we'd be better off. So we
Yeah,
had better
it,
expanders than they did in 1902 also.
I can only
I'm not,
imagine.
I really think that, and I think Liz and I talk about this a little bit, and was kind of some of our focus with Untethered is it's hard to change. We can't, talked about the reasons why it's not going to get to the academic level universally, right? It's hard to have one-on-one conversations and change the mind of individual providers unless they have that personal connection to it. But where I think that there's an opportunity to influence change is educating the parents and specifically the moms, because
Mom army.
there's
I love my
nothing
mom army.
there's nothing more, powerful than a mom that's going to advocate for her child. And with that, I think comes perhaps curiosity. Right now there's a lot of naysayers or shit talking from other providers out there, but I do think it's going to create some creativity or maybe a thought to think a little bit differently, if they continue to have patients demand the care. So I'm hoping that we can influence that as well.
Yeah. Y'all are doing a great job. I watch y'all all the time and on all the different social media sites y'all post on, and you're doing an incredible job. And I know the impact is being felt. And so you can ask yourself, do you realize the trickle down effect and the
It all
Oh,
goes
all
back
that's
to
so
you.
nice.
happens to
I'm
all the people? Says because it actually is occurring. Y'all are doing the exact same thing, and it feels good. I know.
I'm grateful that my ring light died, because you'd see how tomato red I am right now.
Did you
So
get a,
y'all are doing
oh,
a great
yeah.
job. And the other part of you, it came up while you were talking, that the other thing that happens is that more and more the people that buy in, they eventually need to spread the word. So you need to grow the next group of, I know both of y'all have young dentists that you're working with, and you need to grow that next group of people because we have to continue the messaging, but you have to also get outside of restorative dentists and start doing it within specialists, because you really need the orthodontists, the young orthodontists, to get on board and then find more of them to build more momentum towards this, because um, the old guard is very malicious in how they attack people. And I was telling y'all the other night that I think as soon as I settle down, maybe after the first of the year, that's going to be my new project. Is um, I've I've done I've fought as many battles as anybody on this kind of topic, and I don't care anymore about getting in those battles. I'm fine. And I think I'm just going to put together a presentation that's basically here's what you're saying, you're telling people, and here's why it's wrong, and create a resource for everyone. So it would be a lecture, but it would also be a resource that y'all could
You're
go to.
amazing. And
It would be, if your orthodontist says this, here's the citations that you need, and here's a little 2-minute blip that will explain to you why they're wrong about this. And
I
I also
love
think the
that idea.
pediatric dentists, right? Like, I spent a lot of time with a chip on my shoulder when I first was exposed to your teachings, and I was, out there trying to find the ENT, find the pediatricians, find all the people, and no one wanted to shift what they were doing, and I was self-righteous and mad. And finally I got further training and started doing it myself, and I realized, man, 3, 4, and 5-year-olds, that's a tough demographic. So I get it. I can understand how that might change the flow of an orthodontist day, but who better equipped to handle early intervention orthodontics as pedodontists, right? They
And
have the
it's in
training
their
and how
guidelines. They say
it's
to
in
do
their
it
guidelines,
in the
and they have the
AAP.
training of pediatric behavioral management, right? So that even more than the orthodontist might be the
Oh
biggest
yeah.
influence.
Oh yeah, absolutely. And the interesting thing is that every time I'm around a pediatric dentist that does ortho, and I ask, like, do you intervene on 345? And they go, yeah. And they go, is that hard? And I go, no, that's what I do all the time. Like,
Yeah.
it will,
I'll take a 4-year-old over an 8-year-old girl anytime. That's like a existential crisis for them. Like, ugh. But
the issue though is with pediatric dentists doing fillings and stainless steel crowns and stuff is so much money and it's
I
so
know.
fast. And
I'm
true.
glad
so
you touched on that.
care of disease is much more profitable than doing
Preventing
expansion.
it.
You mentioned that, and it brings another thing that I love hearing you say. And nobody really talks about the profitability of adenoids and tonsils versus like a septoplasty. And it's really interesting to hear how low the reimbursement is for adenoids and tonsils in comparison to something like a septoplasty. So why would you as an ENT, if you're like, it's borderline and the parents really aren't into it, why would I convince them if I'm going to get $400 for this? There's
Yeah,
it's
a
for-profit
lot.
business. All of us are.
It's a lot.
But
And you sign on when you do that. It's a 3-month contract with the patient. So you have to manage them for 3 months to to get over that. So you're getting what we get paid to do a MOD composite, right? And you're doing a procedure that could conceivably, although a tiny little number of children pass away, but theoretically a child could pass away, but for sure they could be in discomfort for a while. And you have to manage not only the child, but you have to manage the parent for 3
we
months.
know how hard that is. It's hard to manage because we care. Like as parents, we care. And so it's never ill intent when they need a lot of handholding. It's very much that they're looking for guidance for their child. My ENT today sent me a tongue, lip, and buccal tie release. He texted me, he goes, they're going to call and schedule. And I was like, well, they're, I'm so glad that we're in a place where you'll refer me procedures and I'll refer them to you too. But I'm sure that there's a parental management aspect that can be challenging in an ENT flow of the day too. And when you speak to the orthodontic population, we're lucky enough to know a lot of the colleagues that are getting criticized. And when you say we need to go educate orthodontists, I don't know if my skin's thick enough yet. I
I,
need it to be
I want to
thicker.
leave that one for me.
One of my
Yeah.
favorite things that I've ever seen was it was actually the first time I met Meggie. Audrey Yoon was speaking, and there was this orthodontist that came as a guest to the Milwaukee Forum. It wasn't part of their group or anything, but came to hear her lecture, mainly to just step on her. Every opportunity he would get, he would say, but it's going to relapse, but this is going to happen, but the literature doesn't say. And finally, it's like 3 p.m. by this point, and he'd stood up maybe 6 times, 7 times. She finally goes, I will never let a child be sick because I'm scared of orthodontic relapse. And the whole room just went silent. And he came up to her after and was like, so, how do I do this with my grandchild? It was just such an interesting altercation. And I mean, he came there to try to put her down. And I mean, I know she especially still goes through a lot of that. And she's publishing for Stanford. She's on faculty at like 17 different institutions. Like, it's why do we always have to prove that we're right in comparison to everyone else? Why can't we just agree that maybe we missed something?
Well, the problem with that discussion is they're both right.
True.
Okay.
Sure.
And but the issue that orthodontists can't get over yet is that I don't care about the teeth. I
Hmm.
care about the breathing. So early intervention for me is not about teeth. It's not about the smile. It's not about the bite. It'd be a bonus. That'd be great. But it's about breathing. And so when we talk to parents about early intervention, I never mention this is orthodontics or this is phase one orthodont. I don't call it any of that. This is, we're going to do an expansion procedure to let your kid breathe so that these things, ADHD, enuresis, whatever it is, bruxism, those things, we're going to try to decrease those things happening in your child. And because their brain and body is growing at such a rapid pace right now, anything that's out of whack has a greater probability of causing them a problem. So let's make them breathe well right now. Later, you're going to have to do ortho on this kid. And so, but they'll be healthy and they'll be a different child than my Jake. So if I had gotten involved in my Jake 3 or 4 years earlier, he'd have been different. Now, I don't know how different, but he would have been different. Probably wouldn't have made everything better. I think birthing trauma and some of the other things that happened at that point played a bigger role, maybe, but he'd be different. So why wouldn't you do that? Why wouldn't you just do the best you can to make them healthy and then go, okay, now let's do braces, like on the regular time frame.
Right.
They're 10 now and let's do braces. Well, it relapsed some. Yeah, but they're healthy.
And
So
Well,
ultimately, it makes the orthodontist job easier because we're addressing the
Totally.
foundation putting it in a more favorable position for them to continue to do their job well. It's getting the orthopedics in a better position so the orthodontics can be more just faster for them, easier for them.
Same way it makes restorative dentistry on an adult better when the foundation is correct. Straightening teeth when the foundation is correct is slam dunk. All three of us have been through significant treatment to improve our airways in adulthood. And one of the orthodontists and more recent orthodontic conversations I've had was, why would you put a child through that? You know, it's just a lot. It's a lot of trauma to put a child through expansion. And I was like, it's a lot of trauma to put a child through not being able to breathe. And it doesn't get easier. It doesn't get less invasive. It doesn't get less expensive to postpone. All of the issues just present differently. And I disagree. Being a mom I put my 8-year-old back in an expander again yesterday, and my 6-year-old just came out of hers, you know?
the question, if phrased correctly, in my opinion, the question would be, why would you do that as an adult? Because you're already damaged. It should never be, why would you do that to a kid? They're not damaged. You got to fix them. So if you're ever going to question doing large intervention, like why would you do ortho? Why would you do MARPE? Why would you do orthodontic? You could ask that question as an adult, and I could go, well, you're right, you're damaged, and I'm probably not going to get rid of all the problem. That we could have a conversation about. You can never have that conversation about a child because their brains and bodies are growing. They're changing every day. Every single night they go to sleep and they don't breathe well is impacting them way more than the 40-year-old, 50-year-old, 60-year-old. They're already damaged. So he is saying exactly the opposite of what should be said and thinking the opposite of what should be said. There should be nothing that should ever get in the way of you intervening on a child. In an adult, you could go, well, I'm already screwed. Let's just put me on CPAP.
Mm-hmm.
That, maybe you could say that, but never as a child, ever as a child. You always intervene. And
That's a really good
I don't
point.
even do it. There's no financial gain for me. I'm just saying that makes no sense at all to ever consider like what you're putting the child through. That there's
The argument we'll hear often is, why would you do phase 1 or pre-ortho or anything like that when you could get it all done in phase 2? And it's like, well, you can make your teeth look straight in any bone.
I want a healthy child with a functional brain and a good body and good health. Because the literature is replete with studies saying that you can damage the brain, and more equally as important, you're setting yourself up systemically for being unhealthy for a lifetime. You have problems as a child, you're going to be the high blood pressure patient as an adult. There's no doubt now. If you have, you just set yourself up to be sick as an adult. And the unfortunate thing is we don't ever go back when you become the high blood pressure adult and go, wonder where that came from. And if you look back, you know exactly where it came from. So
Well, yeah, we talk about that all the time. We think about Grandpa Wayne, Liz. Liz, we're going to
Mm-hmm.
have Jeff back. I think we could talk to him for 4 days. If you guys are listening to this right now, share this with your dental friends, your parent friends, pass on this important message. And then also, because we're certainly going to have him back on, ask send us a message and let us know what questions you want us to ask him next. What are you going to say?
Well, I have a list of rapid fires that I have to go through.
Well, let him slam his wine first.
Yes.
Yeah,
Well,
because it was we were kicking off your podcast.
so we got to keep it fun. And okay, so the if anybody's watching this versus listening, the wine glass that Jeff is drinking out of has a skull on it. And we all have this
Only the
infatuation with
maxilla.
skulls. Exactly. We love the maxilla. And my team members found us, they came in the other day and I think they thought it was some like voodoo crystal. But Margaret, one of our other friends where Meggie is right now, had given us a little stone skull and my daughter loves to play with it. And she must have left it some on a windowsill in our new office because she carries it around. They were like, is this yours? I was like, oh yeah, that's just my skull. So, okay. So thank you for cheersing us and kicking this off. But are you an early bird or a night owl?
Um, um, I um, I like getting up early to get going, see the morning light, and get outside and move around. I work into the middle of the night, though. If I'm creating things, I can continue on and go, go, go.
Do you like teaching better or treating patients better?
Oh, I uh, I like teaching better because there are I like the act of treating really well. I just hate people sometimes.
You know, we've all been
Totally
there.
fair.
Sometimes if you could just take the maxilla out of the face and work on it, it'd be good. It'd be good. Okay, endo or surgery as a GP? Would you rather shuck a third molar or do a third molar root canal?
Oh God. Uh, man, that one's tough. I would rather do endo than take out a tooth because
That's
yeah, there's something about hearing a root snap that bothers me. Now, when I was a resident in Connecticut in the hospital, I was the I was a chief resident, and the students would rotate through. And whenever that happened, I'd go, well, if there's no bone, there will be no tooth. So we just started grinding bone away. And it's like but I didn't have to follow up with those people. So who know how that worked out.
okay. Two more. Vodka or tequila?
Tequila.
Duh.
We all knew that answer. Come on.
We had to
Yeah.
give him an easy one. He's been
I don't
struggling
know.
with his
I
rapid
honestly
fire.
don't know if I've ever drank vodka even. Maybe I've sipped it, but no, tequila's mother's milk. So if I had tethered oral tissues, I'd get them released so that I could drink it.
Well, they
So you could
used to
have your
just take that like
tequila.
whiskey finger, you know, they dip it, grandma would dip the finger in the whiskey to get the baby to sleep.
Oh, we my daughter on a long flight when she was a baby, we put Kahlua in the milk bottle. So yeah, she did Kahlua instead.
Well, good thing she's an adult now, so nobody can call CPS on you. If you could be anything in another life, what would you be? An astronaut, a chef, travel writer?
Um, You know what I would love to be? Actually, it's interesting because I was talking to a guy yesterday and he was asking me for advice for a younger sibling and like what would you she apparently has a wonderful mind and wanted to learn. And she asked him like, how do I learn? How do I grow? How do I and if I there were back in the 1800s, they had a thing called the French Salon, and it was just intellectuals that they would they would read the classics and discuss them and discuss. I would love to be one of the people that could sit around and just be smart enough to have known Aristotle and Newtonian physics and all the things that were going on at the time. I think that would be cool just to think all day long.
Well, and in such a way, you've created that through legacy. So even if you can't go back in time, you can still create a future for it. Okay, final question. This is something we have been trying to end our podcast with, but the title of our podcast is No One Told Me. Is there one thing that you wish someone had told you earlier in your career, in dental school, in childhood, that you could go back on and share with others?
Um, You know, yeah, um, in dental, so we'll go to dental school. It's take it seriously because the thing that I remember out of dental school was because I didn't know what I had no idea what a dentist did when I went there. This was because my friend, I was gonna become a physician because that's what my mom said I should be. And so I
Been
was
there. Yep.
raised by my mom. My mom said you should be a physician,
Was
and
she disappointed when you chose dentistry like mine was?
she was, yes.
And now
Yeah.
she goes, and now I'm sure she goes back and is like, I'm so proud of you. It's
No,
all I've ever wanted.
she hates dentists.
Oh, really?
But she constantly goes, I hate dentists. I'm like, Mom, I'm a dentist. So you hate dentistry. Let's work on it. She still hasn't gotten it down. Um, my mom said I needed to be a physician. And so I went through school and then I did an intern, like a little summer program. And I went, I don't want to be that. But I was stuck at that point. And a buddy of mine said, I want to be a dentist. He wanted to be an orthodontist. He said, you want to come down and take the DAT this weekend? I'm going down to Houston to do it. I was like, okay, I'll do it. And on the drive down, he threw me a book, like this big book. And he goes, you might want to look at that because that's kind of what the test is going to be. And apparently I did okay. My grades sucked. So I had to have done really well, actually. So I didn't take school. I didn't do well in school, but I showed up at dental school and day one, the guy goes, don't, C equals DDS. You don't have to kill yourself here. Just graduate and you'll be a dentist and then go from there. And I was like, dude, I can make a C. And so that's what I proceeded to do, just kind of be middle of the road. And I think that if the thing that no one told me was if you put out the effort there, that it's easier later on. You don't have to play catch up throughout your career um, trying to get information that you would have learned at that point in time and have a better foundation. So I caught a huge break that my senior year, Bill Robbins, who y'all met at the Legacy meeting, was a faculty member for a different group. And he allowed me to work with the top students in the class and learn how to do lit reviews. And he worked on a couple of special projects with me. And then he taught me, or he didn't talk me in, he uh, created interest in going to a residency. And then he joined me later in practice, and we developed a textbook together. Um, and then it just got me stimulated to go, okay, I can, this is it. I can do this. I can be better than this. But I never was in dental school. So I would, the thing that no one told me is that it's harder if you don't lay a good foundation early. So.
Fair. It's a really good point. Dentistry is a small world. It's so interesting how your relationship with Bill has continued to evolve and seeing him continue to train others as you are too. It's really impactful. It inspires us, that's for sure. So,
He's
Megs, do
my
you have any other questions?
he's my version of what y'all said about me is what I say about him. So
I love that. I love it. I don't have any more questions. I could talk to
Well,
him forever
thanks,
though.
man. This was fun. I'm so happy that we all get to spend time together, and it's fun to see our worlds all collide and keep colliding. And thanks for talking me off ledges when I need it because I can't achieve perfection, but no one's
yeah,
perfect.
y'all are for me. Mentorship early was just creating interest in y'all, and then for me now it's just occasionally having to like when you're trying to put a boat in a dock, sometimes you bump into the sides. So I'm around there to kind of bump you back into the middle.
That's nice.
Keep on bumping us.
Well, oh, this stuff is also heavy too. Like dentistry's heavy. It's hard to be a clinician and a parent and a business owner. And I think so often we have friendships outside of dentistry, but people don't see us for all that we shoulder, uh, whether it's intentional or it's just part of the path. I think we all need each other. So it's fun to see what you've built in our mentorship group. And for that, we're so grateful. But well, thank you all for joining us on our podcast, and we'll
Thank
see you next
you.
time. Make sure, I think I'm supposed to say you have to like this, So
Share
and leave us a
it.
review and share it and do all those influencer things. Really, we're just dentists trying to be influencers. So thanks for being influenced. All right, we'll see you next time.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about Airway Health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @Untethered Airway.
Until next time, bye.